Hi, this is Sophia, one of the producers of the Docs with Disabilities podcast. In today's episode, our guest talks about the shame she felt about her disability. Shame is everywhere in medical culture. For Docs with Disabilities, shame is a persistent feeling reinforced by our ableist society. This fall, the award-winning medical storytelling podcast, The Nocturnists, launched a 10-episode documentary series called Shame in Medicine: The Lost Forest. This series breaks the silence around shame in the medical profession by exploring clinician stories about training, exam scores, mistakes, being sued, and failing to conform to the ideal of the quote-unquote healthcare hero. Episode 8, In Hiding, airs Tuesday, November 1st, and includes the stories of docs and future docs with disabilities. In this episode, The Nocturnist explores the masks we wear and how in medicine we often bring a curated version of ourselves to work, one that fits into an unspoken code of conduct. The right mask, it is believed, will win the respect and trust of our colleagues and protect us from painful judgments and feelings of alienation. In episode 8, The Nocturnist asks the question, what are the side effects of hiding parts of ourselves at work? And what are the parts of ourselves that remain exposed? We encourage all of our followers to tune into this episode and to engage with the entire Lost Forest series. By foregrounding untold personal stories of our healthcare workforce, The Nocturnist brings a human-centered perspective to the big questions facing our alien healthcare system. Listen in your favorite podcast app and visit thenocturnist-shame.org to learn more. Now, we jump into today's Docs with Disabilities episode.
Doctors with disabilities exist in small but impactful numbers. How did they navigate their journey? What were the challenges?
What are the benefits to patients and to their peers? What can we learn from their experiences?
And how do these experiences differ within different medical systems?
I'm Lisa Meeks.
I'm Peter Poulos.
And I'm Quentin Clark from the Canadian Association of Physicians with Disabilities. And together we are thrilled to bring you the Docs with Disabilities podcast Canadian series.
Over the next 6 weeks, we are excited to present a 6-episode collaboration with the Canadian Association of Physicians with Disabilities.
Join us as we explore the stories of learners and providers who study or practice in Canada.
Welcome back to the Docs with Disabilities podcast. In this episode, we are joined by Dr. Lynn Ashdown, a patient experience expert who advocates for the inclusion of patients in all levels of healthcare. As she will soon discuss, Dr. Ashdown obtained her medical degree from the University of Ottawa and began her residency in family medicine before experiencing an accident near the end of her training that exposed her to the experience of being a full-time patient. In this episode, Dr. Meeks and Dr. Ashdown discuss how Dr. Ashdown's perspectives on healthcare changed after gaining a patient perspective, and how Dr. Ashdown is using her medical training and her experiences as a person with multiple disabilities to promote cultural change and improve curricula within medical education. We begin with an introduction from Dr. Ashdown.
Good afternoon. My name is Lynn, and thank you, Lisa, for having me on this podcast. I'm honored and humbled that you would make space for me. I'm a big fan of the podcast. I am an MD by training, so went to medical school, graduated, and was at the very end of my family medicine residency when I suffered life-altering injuries. And for the last 8 years, I've really been navigating life as a full-time patient.
Your story is quite compelling. If you're up for it, would you like to share that experience with the audience?
Sure, buckle up. It's quite the story. So like I sort of mentioned, trained as a physician and was doing my residency in family medicine. In fact, was at the very end, had just finished and passed my certification licensing exams 3 weeks prior to a day that changed my life. And I remember waking up and I was on an obstetrics and gynecology rotation. And I remember waking up and going to work one day. And then my next memory was waking up in the ICU, obviously very confused, not knowing how I got there, and really completely naive at the time of what my life would end up becoming. What ended up happening was on this particular day, well, I suffered cardiac arrest, which we, after the incident, found out was due to an undiagnosed congenital heart arrhythmia called congenital long QT syndrome. And so often the first presentation is death and cardiac arrest. Witnesses had said that I had been studying in a coffee shop, which was not uncommon for me. That sounds very on brand for me. I was sitting on a stool. And so when my heart stopped, I fell lifeless from the stool. And the way that I fell was just sort of a freak accident. I suffered skull and cervical fractures, a moderate traumatic brain injury, and a spinal cord injury, and then plethora of other secondary diagnoses as a result of that day. But that fall changed everything, and it really divided my life into life before illness and life after illness.
I can't imagine what your first thoughts would have been waking up in the ICU and kind of the total disorientation. And you were in the ICU for a long period of time. At what point did you start to think, oh my gosh, what about my career, my passion? And what were your first thoughts around that?
So interestingly, my career and my life initially, in those first few months, it really didn't cross my mind at all. Just in terms of hierarchy of needs, I was fighting for my life essentially. And after the accident, spent 2.5 years of cumulative inpatient hospitalization alone. That's just inpatient, which I kind of joke that I've done a residency in patienthood as well, in addition to family medicine. The first year, the severity and the consequences of what had happened really hadn't dawned on me. And I also just didn't, from a brain injury perspective, have the capacity to absorb everything. And I was really just a patient kind of in need of attention and observing the system. And it really wasn't until 2 or even 3 years out that I started to think about the profound impact that that day would have on my life. Like, it literally changed every aspect of my life, my physical health, my cognitive health, my emotional health, social health, spiritual health. I mean, not one thing was left unscathed. And it really only started to really kind of sink in a few years after that day, to be honest.
Like you said, you were fighting for your life. And when you get to the point where you think about your career, re-entering medicine and what would that look like? But you also had the opportunity at this point to see medicine from a completely different angle, right? And so you had expertly navigated, quote unquote, medicine and the wards and the clinics as a trainee. And now you are becoming a full-time patient. Tell us what that experience was like as you came into those same settings, but from the different perspective and in a different role.
It was quite profound. And I've recently completed my master's in medical education. And my dissertation was actually looking at medical education from the lens with which I viewed it as a trainee and learner and physician, and then the lens in which I view it now, having experienced being a full-time patient for the last 8 years. And I use the word full-time. I use that not because it's my identity, but it reflects the intimacy and the level of immersion that I've had in the healthcare system. And it positioned me to really sort of have an understanding that most people would never be able to view and experience. And it really has transformed how I look at the role of a physician, the role of medical education. The first few years, there was this feeling and this question that I had of, how can I be so lost as a patient, yet understand the healthcare system so well? If you had asked me before my accident if navigating healthcare and being a doctor would help to prepare me to be a patient, I would have wholeheartedly said yes. Yet, once I became a patient, I found myself in this world that I thought I knew so well, but that I actually didn't know at all, or at least from the perspective of a patient. And it truly had me wondering, what is this gap? There's obviously this big mismatch then between what we learn as physicians and then what actually happens to patients. And so that's really where this idea for my dissertation came from, was just out of my intellectual curiosity to kind of figure out how can I know so much yet know so little at the same time. And I also acknowledge, though, that I talk about how lost I felt and still feel at times now as a patient, but I do recognize I still navigate the system with privilege just by the virtue of the knowledge that I do have. So if I'm struggling and couldn't survive, I can't even imagine how patients without a background in healthcare or the same level of expertise from a biomedical kind of perspective navigate it. And so that's where, interestingly, my experience as a patient has kind of led me down this path of, well, how can I fill in the gaps then? Like, what's missing in medical education, right? And so how do we fill in those gaps without kind of expecting that, every physician can only truly become complete in their education having to be a patient, right? I mean, that's just not realistic. And I don't wish what I went through on anybody. But then it's like, okay, how can I take what I've learned and then fix medical education?
In the next section, the conversation shifts to more explicitly consider the presence of ableism within the medical world. Listen or read along as Dr. Meeks and Dr. Ashdown discuss how ableism impacts their own perspectives, the experiences of disabled patients, and the content that's taught to medical learners.
Even within all of the barriers that exist to equality, whether it's for patients or for providers with disabilities, is this top layer that encompasses everything, and that layer is ableism. Everything that I think about is through the lens of disability, and yet at times, in certain circumstances, I'm ableist. And that is because our society is so deeply ableist, and this is how we were all raised and reinforced in this web of ableism. And I'm wondering how you would view yourself before the accident and after the accident, and what role you think ableism plays in the disparities, the health outcomes, the access to health care that we see for disabled patients.
I appreciate you, Lisa, saying that you're ableist, because I too am ableist. And the reality is that I'm actually still in the beginning phases of kind of rewriting the story of my life, I guess. And I actually was only able to physically out loud about a year and a half ago say the words, I have multiple disabilities. And so that's how entrenched ableism is just within society, is that up until about a year and a half ago, I actually viewed everything from a biomedical perspective. And that's strictly what their diagnosis is and how do we fix someone. I really, for the bulk of my recovery, have just been focusing on my diagnosis, how to fix it, not realizing how intertwined society and ableism is within, all of this. And also just reaching that level of acceptance of and understanding that I'm navigating a world with multiple disabilities that definitely negatively impacts the care that you receive as patients. And medical education is quite ableist, and sort of, I'm ashamed to admit how unaware I was going through medical education, and really sort of not recognizing the privilege that I had just as an able-bodied patient seeking healthcare, but also the privilege that I had as an able-bodied learner and resident. And the reality is that in terms of ableism, it's so entrenched within society that a lot of people I don't even think would be able to define it if you asked them to. If you asked anybody to potentially have to give some form of definition of racism or something like that, they might be able to do that. But a lot of people in society often haven't even heard of the word. And if they have, they don't really know what it means, and definitely wouldn't be able to offer a definition. About a year ago, a physician kind of said to me, "What is ableism?" And to credit that physician, I love that they were curious enough to ask the question, and so I think that's great. But then that also speaks to how we don't even know that it exists. And so if we don't even know that something exists, well, then how do we fix the problem? Right. And so that's kind of the biggest thing that I see, is that we still don't even recognize disability as part of the equity, diversity, and inclusion discussion. There's still a lot that needs to be done in terms of recognizing ableism in society, and then our preconceived notions and prejudice and things that we've been taught over our lifetime, and then having to unlearn and relearn behaviors. And it's a very complex issue. I'm sure you know.
It really is. And I think it's the active unlearning, right? And what I think is going to be so helpful, we're in the middle of developing an anti-ableist training module for undergraduate medical education and residency training. And what I think is going to be so helpful is giving people examples, because it is really hard for people to conceptualize this, where with something like racism or homophobia, it's because we've been talking about that for so much longer, people are able to more readily bring up an example of that and start to unpack what it might mean in other behaviors. But for ableism, people don't readily have examples, right? And so much of our infrastructure, the way we navigate the world, is ableist. So it may not even be something that we voice. Rather, it may be an assumption that we make, right, about
Yep.
what someone is able to do or participate in, or that someone that we don't visibly see as having a disability is just fine and doesn't need any sort of modification or accommodation to assist with participating in an event. I know that some of the advocacy work that you're really focused on right now is bringing this to the medical education curriculum. Can you tell us specifically the ways that you're going about doing that?
One of the things that I've since learned upon becoming a patient is the expertise that people with lived experience have, and that in medicine we don't value that expertise the same way that we value scientific or biomedical knowledge, etc. But the reality is that there is a very significant difference between intellectual knowledge and experiential knowledge. One isn't greater than the other, but they're complementary to each other. In medicine, we really just teach the intellectual and biomedical knowledge, and we really don't focus on sort of the humanistic qualities in healthcare, and they're definitely not emphasized. And if they are taught, it's sort of an afterthought. We enter medicine and we spend the first 2 years learning about pathology and putting patients into boxes and diagnosing them and just seeing patients for a specific disease and considering treatment as simply just diagnosing, giving medications, curing a patient. But treatment is so much more than just diagnosing and, curing a patient. Some of the biggest forms of, treatment that I received over the years has been a physician who validate my suffering, who is uncomfortable with the discomfort that my story brings, who embraces the fact that they actually don't understand. I had one physician who said to me, I've never had a patient in a wheelchair before. Can you help me to learn about this? And that's really profound. And to me, that was one of the greatest connections that I've ever had with a physician, because they were vulnerable and were understanding of their discomfort and owned it and embraced it and wanted to learn from it. But many people still don't see that as treatment itself. Attending to one's suffering and the level of impact that can have, that's just as important as being able to save a life or operate and remove a malignant tumor and that sort of thing. But we still don't value that as being equal, and that's really where people with lived experience can really play a significant role in, I believe, transforming medical education. So this idea of patient partnerships. Right now, medical education is about teaching about patients and disease and pathology, but it's not about learning and teaching with patients. But imagine what we could learn if patients sort of taught alongside physicians and other healthcare providers. There's so much rich data in terms of the experiential expertise that patients have from navigating the system. They are the experts, of their own bodies, but they're also the experts of their disease, and they understand healthcare in a very different level. And that's where I've really come to see the true value. And this journey that I'm on wasn't part of the plan, right? But it's forced me to learn about patienthood. Including learners with disabilities in medical education also is really important, because that also just challenges the narrative and the dialogue and moves it forward, because we're just normalizing it rather than seeing it as something that's a negative sort of issue or something that might be an inconvenience or something like that.
I think the story you told about the physician just asking is such a lesson for all of our listeners and those folks reading our transcripts right now, that first of all, it's okay not to know, right? The most respectful thing you can do is to ask instead of making assumptions, which we know by the work of Dr. Iazzoni and others, the assumptions are what's hurting the disabled population in healthcare.
I have multiple disabilities, both visible and invisible. And if you had asked me before my accident if I felt that people with disabilities had equitable healthcare, I will call myself out. I wouldn't have fully said that it was completely equitable, but I definitely wouldn't have realized how far off from equitable care we actually are. I'm ashamed to admit it, but I do. There's still sort of a lot of people think that if they admit that they're ableist and have bias, that they're a bad person. But you're not a bad person. It's these behaviors that have just been entrenched in us, and we don't know what we don't know. And so we need people to sort of admit and realize that they don't know it but are willing to learn. And so I was under this false assumption that if you see a push button on a door in the hospital and sort of a few designated parking spots, all right, well, we've solved the disability issue in society, right? And that's so far off from what I have now lived as a patient navigating the system. And I mean, the barriers that I face in terms of not even being able to have a proper physical exam because there's exam tables that don't go up and down. And so the physical exam gets deferred. And so from a patient perspective, that's impacting obviously the care that I receive as a patient. But also on the flip side, I think of, well, if we had a medical learner in this situation, then the same way that I can't get a proper physical exam as a patient because the bed doesn't go up and down. If you have a learner that has been admitted into medical school but is in a wheelchair and then finds themselves in that environment, well, then they're actually limited by their ability to do a proper physical exam because the examination table doesn't go up and down. And so this is where it's so important to include patients and people with lived experience in that discussion, because I've learned that by experiencing it as a patient, but then I can take that knowledge and extrapolate and insert it into medical education and be able to see the barriers that patients face are the same barriers that learners will face. The barriers in terms of having physical exams deferred, having referrals completely denied because the physician works in an office that has stairs, and so their entrance isn't wheelchair accessible. Being told that the community sort of imaging center won't take me because they don't do wheelchairs. It's quite shocking, actually. And even if you do get care, I've been sort of in places where often the old school kind of changing rooms for like an MRI or something like that, they're very tiny. And so my wheelchair didn't fit into the changing room. And then they're like, okay, we'll just change here. And I'm sitting in the hall where people are walking down. All of these things that I never would have realized in my training as a physician, but absolutely has profound impacts on the patient, both in terms of their physical health, but also their emotional health. Imagine just being asked to change in the middle of a hall because of the fact that your wheelchair doesn't fit into a change room. I mean, that just affects you psychologically, right? And so it's really important that we teach physicians about this and highlight it and call it out so that we can change it.
Yeah, I can't imagine how demoralizing that must feel. For every single sort of specialty, you can think of multiple ways in which people could be demoralized or have their privacy taken away because there has to be some sort of makeshift adjustment because the space is not accessible. It's not built thinking of people with disabilities, which is so profoundly interesting to me because 1 in 4 patients will have a disability. And so when this probability is that high that you will be treating disabled patients, to have an inaccessible space to me seems like a blatant decision. I'm just so appreciative for all of the work that's being done in this space with research to back up what we already knew, which is some of the healthcare disparities and some of these disparate outcomes are directly tethered to inaccessibility of space, lack of preemptive screenings, people not wanting to engage in healthcare because they don't trust it or because they're having these demoralized experiences, which is really unfortunate.
The conversation now shifts to consider the mental health burdens that are often placed on patients and disabled people as a result of living in an ableist world. Listen or read along as Dr. Meeks and Dr. Ashdown discuss the concept of a good patient or a good student and the psychological impact of these ideals.
You also brought up, I think, a really important point that I would like to shift our conversation to focusing on, which is mental health. And when we talk about mental health on this podcast, we're usually engaging with learners or physicians that have a mental health disability as their primary disability, and this is their area of focus. They do a lot of advocacy on this. But what we don't talk about enough is this secondary kind of development of a psychological disability as a byproduct of the primary disability and the experiences that the person is having with the healthcare system or with the training environment as part of their primary disability. And this could be any disability: learning, chronic health, physical, being deaf and hard of hearing. And I'm just wondering what your experience has been like.
Absolutely. And so when I say that I have, multiple disabilities, both visible and invisible. And I still do have, depression and PTSD from the accident. What was interesting though is that I noticed that in my first few years in the hospital, we expect patients to behave a certain way as physicians, or even in healthcare. There's this unwritten code of how patients are supposed to behave. They're not supposed to cry. They're not supposed to ask questions. They're not supposed to have feelings. And if they do, then, I remember at times sort of crying and then being told, oh, stop crying, Lynn, could be worse. I am always dealing with that in my brain, kind of saying, absolutely. I mean, I fractured C3 and I'm not on a ventilator. I recognize that I'm actually quite lucky in terms of the outcomes could have been so much worse. And so, I'm already feeling guilty that I'm feeling bad about how much my life has changed. But then, we have this idea that, we'll stop crying and that sort of thing. And is it because I'm uncomfortable with that, or is it because you're uncomfortable with that? And a lot of it comes from the healthcare providers' discomfort with emotions. But the reality is that I don't think anybody would go through a life altering catastrophic accident that impacts every part of their life and wouldn't have some sort of psychological impact. And for anybody that says that they shouldn't, it's wrong. There's no way that it's not going to impact your psychological health, whether that's fleeting or it's something that tends to stick around more chronically. Psychological impact from major life changes really happens with everybody. But there's something with disability where people are already uncomfortable when they see me in a wheelchair, or they're already uncomfortable when I have trouble sometimes formulating my words and my thoughts, and my processing time is decreased. And there's so many reasons why people are already uncomfortable. And so then there's this need to have to almost hide the psychological discomfort that I'm suffering from all of this. Because the care providers in front of me are already having trouble absorbing the uniqueness of my story. It is a very difficult story to sort of hear, but then I'm the one that is almost trying to make them feel okay with it. I often feel like I'm not allowed to be vulnerable, and that there's this expectation that I have to be happy all of the time, and that speaks to the ableism we have in society, where we have this stereotype of someone that might be in a wheelchair that's unhappy with the world. And so you're having to counteract some of the negative stereotypes and that people have. It's very complicated, but it's exhausting. And the amount of energy that it takes for me just to do my ADLs every day and to stay healthy and to not end up in the hospital, it's a full-time job in and of itself. And then add in all of these extra layers of barriers, stigmatization, and then having to sort of act like everything is okay to make other people feel okay. It's quite difficult.
I really appreciate you bringing this up because it ties into this idea of the good patient. Who is the compliant patient? Who's the patient that's just very happy to be in that room and be receiving care, not someone who is pushing for more or who is unhappy with the status quo, because that's not allowed. It's really interesting, and I do think this is something that's not often talked about, and it goes untreated as well. So, I know a lot of people who have disabilities of some other category, and the depression or the anxiety that surrounds that goes untreated because the physician never recognizes that this person may need this second line of treatment. So, I think that's something that we could really use a lot of education around, and so I'm hopeful that is part of what you'll be adding in this curriculum that you're developing and in the spaces that you're going into and talking about the experience, is to make sure that people are checking in on the mental health as well as the physical health of their patients, and not in a way that is dismissive or parental, but in a way that just really allows, kind of opens the space up for people to actually be vulnerable and to be honest about where they are with their mental health.
Yeah, and to just add to that, Lisa, as part of my dissertation, sort of one of the topics that I spoke about is, this idea of what's considered a good patient. And so there was this systematic review that kind of labeled a good patient. The three that stand out to me it was obedience, showing up to clinic when told, and showing enthusiasm and compliance for treatment. And I mean, just like let that sink in. That's so I don't even have the words. My brain injury is preventing me from being able to actually eloquently state how warped that is. It's disheartening. I mean, is that all we expect of patients? But this idea of even compliance with medication. Well, there's so many reasons why a patient might not be taking their medication, and many of which has nothing to do with the patient themselves, right? I mean, just that statement in and of itself is so complex because we're assuming that patients have the money to be able to buy the medication, that they understand what their illness is, that they don't have some disabilities that prevents them from being able to remember to take their medications. I don't know about you, but I'm not always enthusiastic about undergoing treatment that's going to be painful or harmful. I wasn't going into spine surgery saying, awesome, this is going to be fantastic, right? I wasn't enthusiastic about it. I was nervous. I was scared. We have very high expectations of our patients.
So you just finished a master's in medical education.
Yes.
Congratulations. And what's next for you?
Yeah. So, not that there's ever a good time to suffer a catastrophic accident or life altering injury, but, I had even written and passed my family medicine licensing exam and just had a few blocks left before I was officially done. And so, it's not off the table for me whether or not I am able to return clinically. At this point, I'm just not capable enough of fulfilling some of the requirements, and I always look at what would be best for the patients, even if I want to be practicing clinically. If my brain injury is sort of impacting my ability and my cognitive fatigue that kicks in after a few hours, well, that's going to impact my ability to make appropriate decisions and give the best care for patients. My brain injury has been improving from the moment that I came out of a coma. I couldn't even put a few words together initially, and so even a few years ago, to say that I would have been doing a podcast, there's no way that I would have, I would have even thought that that was possible. So I continue to work really hard and believe in the power of, the plasticity of our brain, and that it can continually improve. I'm still working hard at that. And so, it's not off the realm of possibilities, but I also know that I'd be facing an uphill battle in terms of having to fight for accommodations. And so, I mean, that definitely comes into your decision making as well, is that, well, to be able to do my job properly just with all of my illnesses in and of itself is going to be hard. But then you throw in the extra pressure of having to fight for myself and advocate and sort of be the person that's breaking down the wall. It's just a whole extra layer of burden and responsibility. In the interim, I'm really sort of getting into the expertise really of the role that patient partners can have in improving healthcare, medical education, and I'm really trying to also advocate for society to recognize ableism more, but then also to try to advocate and change our lack of attention that we're paying to ableism in healthcare and medicine right now. And so, like I said before, we still don't even really think of disability as part of, equity, diversity, and inclusion talks. For me right now, I'm really trying to challenge the narrative within medical education across Canada and sort of get that message out that disability is part of the equity, diversity, and inclusion discussions, and then also then advocate for actual teaching around disability in our curriculum. I mean, it really isn't done at all. And when it is done, it's often very, very outdated, methodologies, and at times definitely inappropriate. I mean, there's some schools in Canada until very recently that thought that the way to teach about disability was for students to spend a day in a wheelchair, and that was supposed to give them insight into what it's like to live in a wheelchair. I look at that through the lens as someone who lives in a wheelchair day in and day out. And I mean, spending a few hours in a very catered and fake environment is not an appropriate way to learn about the actual lived experience of navigating the world in a wheelchair.
I'm so glad you brought that up. I cannot tell you how many people still believe that this is a appropriate way to be teaching, whether it's deprivation of hearing, deprivation of vision, or the use of a wheelchair. It is
Yeah.
mind-boggling to me how disrespectful it is to the person who lives this experience every day, and yet how many people include this in their curriculum. And I really think it is one of the great examples of not only ableism, but privilege and power. Um,
Absolutely.
making a decision about how to teach about a concept, because as you have said, you would never endorse this as a way to understand your lived experience, and yet it happens all the time. And so
Yeah.
I'm so glad you brought that up. I don't think that anyone on the podcast has ever discussed that. And
Yeah.
it really is a really important concept of something that is being done all the time.
In this final section, Dr. Meeks and Dr. Ashdown discuss Dr. Ashdown's work with the Canadian Association of Physicians with Disabilities and Dr. Ashdown's advice for learners with disabilities who are listening to this episode.
Lynn, can you talk about your involvement in the CAPD and what it's done for you? What role it played in your life and in your recovery and continued engagement with medical education?
Absolutely. It's, honestly, it has actually been quite empowering and therapeutic actually for me. I talk about sort of how I want to make changes for other people and for medical culture and healthcare, et cetera. But, truthfully, it's actually been quite healing for me to be surrounded by other people with disabilities. And that's something that up until about a year and a half ago, I hadn't really been around. I was still very isolated in my world of just sort of being a full-time patient, and then sort of, relationships with people that were pre-accident. So all able-bodied people that just, although have been very open to learning about disability, sometimes there's a certain different level of connection when someone just kind of gets it, when you don't have to explain something. And so it's been quite therapeutic for me, and definitely a learning experience for me as well. Although I have multiple disabilities, I mean, the range and diversity of disabilities in and of itself is quite vast. And so I've actually learned a lot about other disabilities that I'm not living. So just by being in that environment as well, I've gained a better understanding of sort of the lived experience of other people. What we're really trying to do is it has just really allowed a platform and a way for me to start to name ableism for what it is. And again, that's not a bad thing. And I don't want to shame or to make people feel bad if they don't recognize that it exists, but we don't know what we don't know. And so the work with CAPD is really a way for me to really actually educate. And I actually see myself as being someone that can be on the forefront a little bit of being able to get people to listen and understand that disability is part of the equity, diversity, and inclusion discussion. And then also recognize that we need to do more teaching around disability within curriculum itself. We need to admit more students into medical education with disabilities, both visible and invisible disabilities, but also do a better job at, once they're admitted, of allowing them to flourish. There's one thing to let them in. It's a whole other thing that they need to be supported and be given the same opportunity to flourish as an able-bodied peer. But then also what it's allowed me to do is the Association of Faculties of Medicine of Canada, the AFMC. I've been sitting as a patient partner on their educational committee for a new conference next year called the International Congress on Academic Medicine. And one of the three plenaries is actually on ableism in medical education, which is, that's a first. And so I see that as here's an international conference now that brings together people from all over the world of all different areas of academic medicine, and ableism is being given a spotlight. And I'm really proud of that. And I'm really proud that the medical community, is at least leadership, is really trying to embrace and learn and listen to patients with lived experience, but also the messaging that CAPD is trying to get across as well. I see that as a really big victory, and I'm really looking forward to that plenary next year in 2023.
I'm so grateful for your willingness to share your story. I know that many of the things you said today will resonate with so many of the listeners of all different types of populations. But we do ask one question of every interviewee, and that is, what advice would you give the learner with a disability entering medical education who is beginning this path? What things would you want for them to know?
I think one of the things that I would want them to know is that it's okay to not be okay. It's okay to need help, and that's not even specific to necessarily a learner with disability, but I mean any learner. We still have that culture where we just expect everyone to be perfect, which we know isn't appropriate. To sort of recognize that, yeah, that it's okay to not be okay. It's not weakness to need help. I dream of a day where accommodations aren't seen as such a difficult thing, and that we just see accommodations not even as something that's like special treatment or anything like that, but part of helping learners and then subsequent physicians thrive. And I think that what I would say to learners with disabilities is that even if it seems harder at times, the value that you're bringing is worth it. The value that you're bringing to medical education, and then more importantly, the value that you're bringing to patients that you will be serving one day, is immeasurable. Those patients that you see will thank you, and they will be privileged and so lucky to have you as their physician one day. So kind of when the going gets tough, to realize that you bring a certain level of expertise and maturity that many of your perhaps able-bodied peers don't have. And that will ultimately help you to be a better doctor.
Thank you so much. I would absolutely agree with everything you've said. And we're so excited to see more and more learners coming into the space and proudly disclosing their disability identity and really expecting the accommodation and the equal access that they deserve. So we're excited to see what the future holds. I really appreciate you coming on today, and I look forward to reading that dissertation if you will send me the link.
Absolutely. And thank you for having me. I really appreciate it. And thank you for all your advocacy and work. And I've learned a lot from just following you and reading all of your publications and your work and listening to the podcast. So I thank you for helping me to evolve in sort of my journey in my new world.
To our guest, Lynn Ashdown, thank you so much for joining us for this episode. We are so grateful for your openness in sharing your story and for your generosity in sharing your wisdom with our audience. To our audience, thank you for joining us for this episode. If you liked this interview, we encourage you to listen to the other episodes in our ongoing collaboration with the CAPD, to subscribe to our podcast so that you never miss an episode, and to check out the Nocturnus series on shame in medicine. We also encourage you to check out the International Conference on Academic Medicine, which will be hosted by the Association of Faculties of Medicine of Canada in Quebec City in April of 2023. The keynote for the conference will focus on ableism in medicine. Head to icam-cimu.com to learn more. This podcast is a production of the Docs with Disabilities initiative as part of a special collaboration with the Canadian Association of Physicians with Disabilities. This podcast is supported in part by the University of Michigan Medical School Department of Family Medicine Disability Program, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. This series was made possible through funding from the Canadian Federation of Medical Students Strategic Innovation Fund. The opinions on this podcast do not necessarily reflect those of their respective institutions, partner organizations, or funders. It is released under Creative Commons Attribution Non-Commercial Non-Derivative License. This series was developed by Quentin Clark and Lisa Meeks and produced by Lisa Meeks, Sophia Schlossman, and Jacob Beeman.